Due to the coronavirus, lots of American invited speakers didn't attend this meeting, so that a lot of programs have completely changed. In this session, the first topic is HLHS, a newborn surgical options and outcome, and by Dr. Sakamoto. And the second topic is the mitral valve repair in children by Dr. Sicek. And the third one is long-term result of bilateral banding versus primary Norwood by myself. Okay. The second topic also, the second session also changed. The first one is operation for interrupted aortic arch with LVOT obstruction by Dr. Talwar, and then the second one is aortic valve repair for neonate with critical aortic stenosis by Dr. Sakamoto. Okay. Let's start the first topic. Dr. Sakamoto. Did you change your topic too? Again?
Thank you very much for introduction. Very sorry. So yesterday I got the information. Please make another presentation today. So I did to change my title. Commonly atrioventricular valve repair on functional single ventricle. So sometimes I talk to this one. So maybe someone in this room already got the information, but so I'll do. Patient who is functionally single ventricle someone has well-competed AV valve, someone poorly competed atrioventricular valve, and with time and aging, mortality rate is increasing. And some patient with single ventricular physiology can reach Fontan compression without significant regurgitation. Together with the acceptable valve function with good leaflet coaptation and apposition height, coaptation height. Why does AV valve regurgitation occur or deteriorate? Who is the target for atrioventricular valve repair? When do they need the repair for atrioventricular valve? Congenitally poorly competent AV valve has these factors. Dysplastic valve with hypoplastic leaflet, abnormal commissure and cleft and so on. Badly floating tethered valve with ritual coaptation height. Annual dilatation during fetal period with bad leaflet apposition. Worst group usually have high drops. So worst group die before birth. And another one is worst group can get birth, but very difficult. Intermediate group and slight group and nearly acceptable valves. And all the patients with single ventricular physiology have these above causes. Preparative status, volume overloading period. Glen, volume correcting, and Fontan, volume unloading condition. So let's start. Nearly acceptable valves. Those patients with single ventricular physiology have a possibility to have AV valve regurgitation together with time and ventricular function related. Anyway, annual dilatation with less apposition, less coaptation height than normal. That's the reason why those patients have the regurgitation. So those patients with less coaptation, less apposition, circular angioplasty is reasonable to make a better apposition or coaptation. Anyway, previously, that report is made by Dr. Imai, Professor Imai, Japanese big cardiovascular surgeon, 20 or more years ago. So previously, the target for atrioventricular valve regurgitation was those group because we could not rescue the difficult groups and tried to intermediate group, mild to moderate dysplastic on tethered valve with worse position or coaptation height. So 2007, our colleagues, my colleague in my hospital, Sakakibara group, Japanese Sakakibara group, reported this one, edge-to-edge repair for common atrioventricular valve in single ventricular physiology. These ones. Of course, edge-to-edge repair is effective to make better local apposition, pinpoint local apposition, but it does not give better apposition and deeper coaptation height in the wide area. That's the reason why just as operation, good, but 1 week later, 1 month later, regurgitation. You know, and you had an experience. And worst group. The valve requires most demanding strategy, including not only fine surgical technique, but also more detailed diagnosis because of the special feature on their valves, moderate severe dysplastic tethered valve, usually not prolapse. This group has dysplastic tethered valve. That's the reason why deep regurgitation with lateral position. Anyway, this difficult group has immature small baby, restricted tethered valve with thin and fragile leaflet. Common AV valve having various and multiple from small to large leaflet in dysplastic and size. Preparatory stage before Gren and Fontaine having volume overloading to the ventricle and the AV valve. Hard to get a long-term reliable result. Anyway, this is a report from Toronto Children's Hospital. 6 kids have reported the AV valve repair in patients with single ventricular physiology. Among the 57 patients, just 2 had a repair before Glenn. So, you know where? Lateral information are there in this group. Our approach, I show. Before showing my approach, this is a very interesting report. Repair of the atrioventricular valve regurgitation in the modified Fontaine operation from King's Federal Hospital. Many cases are there. In the discussion, there was a very interesting comment. There was a noticeable discrepancy between the preoperative echocardiographic grading of the AV valve regurgitation and that of intraoperative evaluation by surgeon. What's the difference? What's the discrepancy? So, echo and intraoperative finding is different. That's the information from that report. Why? What affects the discrepancy? The plane of the AV valve faces larger posterior aspects, especially in a spinal group like that, posterior facing. Echocardiologist checks the AV valve condition under the beating heart in situ. And the surgeon checks it under cardiac arrest with the plane of the valve being converted from posterior to anterior. So, the shape of the AV valve and the ventricular mass, including tension apparatus, may be considerably changed. AV valve performance, including coaptation and regurgitation, is affected by this change. This must result in discrepancy between 2 physicians, surgeons, and cardiologists. Anyway, so one day I had a regulatory issue. I closed the commission, judged to be by water injection test during the operation, but it was not the commission pointed out by preoperative echo. Amazing or not? This is not unusual, but I think usual. So we need common words to find out where is the regurgitation point between physician, echocardiologist, and surgeon. Common words, common sense, common image. Oh, sorry. So, in our hospital, Dr. Ni, my colleague, reported the classification of the common AV valve in the single ventricular physiology. Type A, B, C. Balanced, unbalanced, single. And regurgitation point is checked together with this information. So our colleague informed me detailed guide map of the atrioventricular valve, like that. Anyway, my strategy, reproduce preoperative echo finding during the operation together with multiple tractions and select, like that. Oh, no need. Together with, usually open the left thoracic cavity to make a reasonable position of the heart and atrioventricular valve to, like that. Anyway, multiple. Usually from 4 to 8 traction suture to make a reproduction of the preoperative echo finding. Anyway, and select potential leaflets and remake them potential leaflet to let grow better depending the individual product if needed be. Make better position between the potential leaflets, mainly using commissuroplasty. So like it's okay. It's on the international bridging abdominoplasty. And after the first or initial surgical intervention, we use multi-stage repair together with new consideration of staged annuloplasty theory. So commissuroplasty, like a K, like that, very simple, figure about it. Reduce annular size, make better positional cooptation between adjoining side-by-side functional leaflet, together with the closure of severely disparate commissure, like that. This is the image of the cap commissuroplasty technique, like that. Deeper cooptation stitch, at the same time the shallow cooptation stitch. Anyway, like that. Very small disparate leaflet is closed, like that. On the selected leaflet can leave the capacity of growth because base of the annulus is natural and can leave both capacity of growth and ability to repeat repair without unnecessary reduction of their annular base. Large leaflet can keep the potential to grow. Another one is, internal bridging. This one is cooptation, not so bad. However, sometimes central regurgitation occur because of the worse opposition between the facing leaflet. So I sometimes do use this bridging to make her opposition, facing opposition, like that. This is the image. And after setting the bridge, and after that, sometimes adjust the length of the bridge. Anyway, I show this technique. This is not a neonate or infant, this is showing regurgitation. So multiple regurgitation around moderate. So echo, and sometimes now, recently, from 2 years ago, I do use sometimes the 3D model to check the area and the position between, together with the echocardiologist. And we check the conduction system valve, and maybe here. That's better, very easy to understand together. You can see 10 kilograms, so not neonate or very early infant. So water injection test. Yeah, not so good. And after that, commissural anaplasty, figure 8. You can see, yeah, very simple way to make a better position at the joining leaflet. Here another one is water injection. Again, leave the regurgitation here, but apposition is not completely, and coaptation height is shallow. And finally, I add the bridging to make a deeper coaptation and apposition better. So this length is almost normal or less, however, not so bad, central regurgitation. And anyway, central regurgitation here, so strength. I did this side, not edge to edge, open, together with bridging. Water injection test. Yeah, almost perfect. Anyway, so after that, multi-stage repair, staged repair. This one, sometimes regurgitation coming like that, and we can use the repair on the AV bar. At the time, at the Green stage and the Fontan stage, the stadium anaplasty theory, the patient requires 100% tricuspid opening of the atrioventricular bar, Green stage, 100% mitral, normal mitral size, and Fontan stage, 80%. I did this strategy. Anyway, after getting the information of the bar, you can see, try to make lead repair of the bar. Sometimes they cut the bridge and repair again. Anyway, another one is edge to edge, because this patient is not a neonate, so we can make edge to edge if needed. So another one is aggressive repair, bar replacement or repair. One aggressive repair is like that. So this one is 2 years, half maybe. And that's a Fontan compression. I did this AV bar plasty together. So tethered posterior leaflet. So I cut additional tension apparatus. However, I could not get the better results. So I finally decide leaflet extension using autologous pericardium like that. And finally, even on this patient, I did use bridging to keep the form of the common AV bar together with the better position. Anyway, so 3 years ago, I reported long-term outcome of a patient with right atrial heart, atrial isomeral after common atrioventricular plasty. I had experience on 59 patients, and 29 had common AV bar plasty, 13 before Graham. And this one is before 2010. Graham group, before Graham group has the worst outcomes, together with conventional historical techniques. However, together with commissural anaplasty, internal bridging, and staged anaplasty, after that, the result getting better, in my experience. Anyway, thank you very much, and this is the conclusion. We have got the acceptable result on AV bar repair on the patient who had the repair at the end of Graham now. However, the patient who required AV bar repair before Graham stage, so very early infant, had and have worse outcome even now. Our approach for the special and difficult patient using detailed reproduction, commissural anaplasty, interannular bridging, and multi-stage anaplasty may give better outcome. I believe so. Thank you very much for your attention.
Thank you, Dr. Sakamoto. the very difficult anatomy, and it's also the very difficult to control the AV valve dilatation in the single ventricle patient. Is there any questions? Is there any like a difference of technique in usual single ventricle and the heterotaxy
Yeah.
patient?
Yeah, so my approach is not to use edge to edge in the neonatal or very early infantile period because so to judge the stitch site location is not so easy to do. And if the patient having so edge to edge had require knee operation at the time, very difficult to repair.
No, is there any different technique you use in heterotaxy?
Yeah,
or
heterotaxy.
non-heterotaxy?
Yeah. Heterotaxy is more difficult because dysplastic level of the common AV valve is different from the usual single ventricular with common AV valve. Sometimes very small and dysplastic. So on the patient with heterotaxy, I sometimes use a little bit larger commissuroplasty to close not only commissure, wide commissure, but also commissure together with small leaflet, all including, and so make a position and a little for leaflets. That's maybe so a little different.
The patients who have undergoing the Norwood operation, many of them have got the TR. So how does the repair of that condition differ from that of heterotaxy? There the AV valve is single and it's not likely to be two components.
Yeah.
And it's a bad subset again, because if you don't correct the TR, then you're in a big problem. So how it makes different?
TR or hypoplastic?
Yes.
Yeah. So from several years ago, I did use this technique, especially the interannular bridging on hypoplastic syndrome together with TR, because hypoplastic syndrome has round-shaped tricuspid valve. However, usually tricuspid valve is not spherical, but not round. So I did make a form. I did make a change the form, changing the form of the tricuspid like that. So, and after that, someone maybe half to 70% on the hypoplastic together with TR had a better result. However, sometimes those tricuspid valve has severely dysplastic, not only round-shaped, but also cleft. Other times, we need edge-to-edge or commissuroplasty and others, so like a common AV valve.
And how much TR do you accept at the Norwood time? Because these patients are going to gland.
So just after the operation, usually less than mild, or less than mild, or mild. Yeah, so anyway, today's target is before gland, so volume loading stages. So that's the reason why, if the patient has moderate regurgitation together with cardiac arrest, so 2 or 3 post-operative days had a difficulty together. So you know where one day, the first day or second day, the cardiac function decreases and improving. So that's the reason why. So I do use this technique to control less than mild or moderate regurgitation.
And sometimes what happens is at the time of the gland, you have the moderate regurgitation. So do you address that? Because people say that if you do a gland, then because of the unloading of the ventricle, the regurgitation becomes less over a period of time. That is also one of the strategies.
Oh, so maybe so. You are saying that, if the patient had a patient who heard this strategy, if the patient has regurgitation at the gland stage, at the time, I do again this approach together with the cutting the bridge and check the valve.
But when you have moderate regurgitation at the time of gland,
Yeah.
Let's say you have moderate
Yeah. Thank you.
you do it or
You leave it. Yeah.
Yeah.
Exactly.
So, thank you so much. And so at that time, so I would like to get the intimate collaboration with echocardiologist. And if we can make an image to adjust or control the AV valve condition from mild to moderate to mild, just one stitch or two stitch. At the time, I do.
So limited repair.
Yeah.
Okay, the other thing is, like when you're going for a Glenn for the second stage, now a lot of people, a patient has had Glenn and you have moderate MR, moderate AVL regurg. Now, if you read the papers from the Chicago group,
Yeah.
they will only deal with the AV valve and
Yeah.
then postpone the Fontan to a next stage.
Yeah.
They said that the mortality becomes less if you fix the AV valve, and then after 6 months or so, go for the Fontan. So that is the policy which I also have followed. And many times at the time of the Glenn with the AV regurg, so what my policy has been to fix up the AV valve, and if the patient is going for a Fontan, then do a lateral tunnel Fontan instead of an extracardiac Fontan, because it is easier to take down and you can fenestrate it easily. So what is your policy in this patient?
Yeah. So, anyway, so at the grand stage, if the patient has a mild to moderate regurgitation, so we expect the volume unloading effect by the Glenn and Fontan. However, so now we can make intimate, detailed echocardiography, and so to check the condition of the AV valve. At the time, maybe just a coaptation and volume size of the annulus and ventricle at the time, volume loading is effective. But some dysplastic condition on the leaflet, at the time, regurgitation continues. So I changed the mind to make a repair.
So that point is well taken. I am just trying to address the issue of whether you will go for lateral Fontan or extracardiac Fontan.
That's a Fontan.
Extracardiac still, lateral.
Yeah, even using extracardiac, I do make a stitch because after the Fontan, the regurgitation time increasing.
And you leave the fenestration so that
Yeah.
there is no problem.
Yeah, at the time.
Okay, thank you very much.
Okay, thank you. The next topic is the mitral valve repair in children. Dr. Sicek.
Good afternoon, and sorry for changing the topic because it was this was given to me yesterday, and I had to pick and set something last night, and this is a brief report of my experience. I have nothing to disclose. And surgical management of mitral valve disease in children is challenging because of the delicate and fragile nature of what happened. Oh. Something going on. Okay. It's okay now. And the pathology is changing. What's going on? And there are high incidence of coexistent cardiac anomalies. I need to have my slides, sir. Okay, surgical options in children are unfortunately very limited, and I believe mitral valve repair is the only viable option. However, in decimal cases, a replacement might be indicated with different prostheses, mainly with mechanical prostheses, because of the quick degeneration of the tissue prosthesis. And very importantly, okay. And unfortunately, any replacement has poor long-term results with 10-year survival of mitral valve replacement changing between 30s to 70%. Mitral valve reconstruction techniques learned from adult practice were successfully applied to pediatric setting, and they are important since there are different anomalies which might require the expertise from our adult colleagues. Mainly mitral valve repair conserves subvalvular apparatus, ventricular geometry, preserves LV function, and definitely gives survival benefit on the long term, and there is no need for anticoagulation. Excellent reports have been reported by several groups on mitral valve repair, with mid to long-term survival changing between 80s to 97%. And freedom from reoperation is important as well, and freedom from reoperation at 15 years. At one major study was 67%, and that changed from 40s to 80% on long term. And these are much better results compared to any valve replacement procedure. This paper from Korea reports 139 children who underwent mitral valve repair between 1988 to 2007, age ranging from 2 months to 17 years old, and freedom from reoperation at 15 years is close to 80%, which might be accepted as excellent for this difficult group of patients. And they also analyze the risks for mitral valve reoperation, and the major risk for long-term reoperation is associated cardiac lesions and residual mitral valve dysfunction at the original operation. Increases the risk for reoperation almost 5 times. 26 patients required 29 reoperations, and very interesting, re-repair was successful in more than half of the patients who underwent a reoperation, emphasizing the importance of expertise on valve repair. The group from Melbourne reported midterm results of repair-oriented policy for congenital mitral valve disease. There were 71 children, 14 patients underwent 17 mitral valve interventions, 14 repairs and 3 replacement for reoperations, and indications for mitral regurgitation, rupture or repair, and severe stenosis. And they report that suboptimal primary repair is a significant predictor for reoperation, but re-repair is most often successful. Before proceeding with any valve repair, exact assessment of the valve anatomy is extremely important, and a surgeon should be able to evaluate echocardiography and then have ambition the anatomy in his mind before going to surgery. Annulus might be small versus restricted. There might be supraannular, intraannular fibroelastic rings. Leaflets should be evaluated for restricted mobility. Most of the time, this might be due to intra-leaflet thickening or hypermobility, excess tissue, or chordal elongation or rupture, or lack of chordal support, and most importantly, subvalvular area. Probably this is the most difficult area to address with the repair. Fibroelastic tissue problems, short or motor chordae, and excess cords or papillary attachments making leaflet tethered. A functional approach as described by Carpentier is very helpful. Etiology gives us the idea about the progression of disease. Dysfunction gives us which type of repair should be used, and the lesion itself is the major determinant of if the repair would be feasible or not. These are my own experience with mitral valve reoperations. There were 36 patients with type 1 normal leaflet motion. All of them had annular dilatation as the major reason, and cleft problems on 21, and leaflet defect in 5 patients. There were 14 patients with elongated or ruptured cornea, and 10 patients with restricted leaflet motions, commissural fusion, abnormal leaflet pliability or short cornea, and 11 patients with mitral stenosis. Unfortunately, 9 of them underwent mitral valve replacement. These are not, again, primary cases, and redo mitral stenosis is extremely difficult lesion to repair. And what is used, zone of position repair in 21 patients, 14 of them re-repaired. There were problems with the primary repair, and 7 already left untouched at the primary operation. 36 patients had additional annuloplasty, some of them with Wooler K, 14 of them ring, and 16 of them partial rings, posterior rings, and 6 patients underwent H-to-H repair, 19 patient leaflet augmentation, which is an important technique for this kind of patients. The approach is very important, exposure is very important, and every millimeter counts in small hearts, and all of the patients underwent this operation through a transseptal approach, which I believe gives the best approach for small children, and I kept a low threshold for extending the incision into the dome of the left atrium and create an optimal exposure of the valve, especially in small patients. Intraoperative valve testing requires that valve be undistorted while static testing is taking place, and the problems with the operations were elaborately addressed by Dr. Sakamata during the first presentation. Here is approach. Right atrium was open, and it was approached through the septum, left atrial septum. Keep the incision towards the right side of the septum, and this gives really very nice exposure, unrestricted exposure to the mitral valve. This is again much better direct exposure to the left AV valve. And if you might want to extend that incision superiorly towards the dome of the left atrium. And here's the mitral valve in just let me see. Make this quicker. Full exposure of the valve. Annular and leaflet restriction is a problem, and removal of fibroelastic tissue from the annulus and leaflets kind of peel-in operation. Oh, this video is not working. Might be a good addition to repair, and you just peel that fibrotic tissue over the leaflet tissue, like the operation described by Dr. Tawazak and Dr. Kumar. It's a very good technique. And leaflet defects, mitral cleft is one of the major problems, and it's a major determinant of reoperation if left open during the original operation. And long-term regurgitation alters the pliability and elasticity of the leaflet and decreases the chance of satisfactory result. Closing a cleft virtually carries no risk, and results are excellent. And patient with cleft mitral valve will be referred as soon as their regurgitation is greater than moderate, even they are asymptomatic. And again, this is one of the most satisfactory operations, and cleft could be repaired either a direct suture technique or with a pericardial patch when a large leaflet tissue defect was present. What is important is just to free the infra subvalvular tissue that restricts the leaflet movement. And here's leaflet closure, and 21 patients had leaflet closure as a part of their mitral valve repair. Patch augmentation, again, is an invaluable tool, and it compensates the lack of native valvular tissue, increases the area of leaflet tissue to permit a larger annuloplasty. I prefer to use slightly treated autologous pericardium that match the flexibility of pediatric valvular tissue, and 19 patients leaflet augmentation was used, 11 of them anterior leaflet and 8 of them posterior leaflet augmentation. And on the anterior leaflet augmentation, it's important to tailor the shape of the patch to prevent aortic cusp effect. It is important. And here is anterior leaflet augmentation with a pericardial patch, and it's important to mobilize the underlying papillary muscle and chordal apparatus, as simple leaflet augmentation without increasing the excursion of the free edge will not improve coaptation. Leaflet prolapse might be due to congenital lesions or acquired in pediatric patients with rheumatic and endocarditis issues. And this could either be repaired by chordal transfer, resection, or artificial chordea. Subvalvular restriction probably is one of the most difficult part of the repair. And there are, here, let me see this movie. It's not working again. And there are different techniques, including the papillary muscle release and addition of leaflet, addition of chordal attachments, and dividing the papillary muscles to create better mobility. And posterior leaflet mobilization is, again, could be done using detachment of the posterior leaflet and then release the tissue to provide, unfortunately the videos are not moving, free leaflet movement. Angioplasty was used in 36 patients. The problem with the kids is the growth issues. Remodeling ring each time an adult-sized patient could be inserted. For younger patients, an intermediate and posterior angioplasty with a PTFE band or very small only with volar K-tap angioplasty was used, and incomplete rings are with pericardium or valves, divided valves could be used in children. And the goal is preserve the growth and respect rather than the resect, and do not close anything anatomically functional. Try chordal transfer instead of replacement. And the angioplasty is an important part. However, because of growing problems with the kids, angioplasty is a limited applicability. Thank you.
Thank you, Dr. Sicek. This is also the very difficult topics in children, which is completely different from adult. Is there any question or discussion?
That was a nice presentation. I was wondering what kind of ring do you use for angioplasty?
For angioplasties, and if it's adult size, and I use a full ring. If some of these patients are adult, but for small kids, it's mostly pericardium. We create our own rings, and we don't use a.
Yeah, sure.
Yeah.
Have you had any experience with the biodegradable ring, which Dr. Kaling is?
I used that ring probably 15 years ago,
Okay.
and I did not have the optimal results, to be honest. And then instead of using that, I'm using a slightly treated pericardium or a tissue, and then use it.
Have you ever considered using an absorbable suture material like PDS for the ring? You use the PDS suture.
Yeah.
So
PDS or it's that ring is practically kind of a PDS suture.
Yeah. Sure. Thank you.
Is there any other comment?
Thank you very much for your information about the difficult target, especially in the neonatal or infant, together with mitral stenosis, dysplastic and others. Maybe so you're making a small cut on the commissural others. At the time, sometimes we got mild to moderate or severe regurgitation. So if the commissurotomy or leaflet cutting, after that, if the patient has regurgitation more than moderate, at the time, what kind of next approach do you have? Leaflet extension on the neonatal very early infant?
To be honest, it completely depends on how the rest of the operation went, and it might sometimes it might be very difficult, but you have to use every means, and could be leaflet extension, closing that area again, and.
Thank you. If you're having so, I would like to know. Thank you so much.
The only thing, I don't want to replace that valve. It's and.
Too difficult to replace the over 60
millimeter. That expandable valves, but on our experience, Melody never worked, and that's a less bailout or resort, and unfortunately, for me, it never worked out.
We have dilated many times.
Yeah.
One of the reasons, things which I've been doing is for older kids to assess the valve, because the saline test sometimes is not very good. So with the aortic cross clamp on, you reperfuse the aortic root and let the heart beat.
Yeah.
So if you reperfuse the warm blood and the heart starts to beat, you can actually see the valve in a very good shape, and then if required, you can do a correction.
Yeah.
And I worked with Dr. Sampath Kumar, so like the technique of the peeling the valve, it is phenomenal. I think I wrote up a paper in JTCVS in 2005 of 305 patients or 375 patients undergoing a mitral valve repair, all of them less than 12 years. And almost 80% of them had this peeling, because once you do the peeling, it extends the length of the posterior leaflet, and it really makes these valves competent. So you don't need to use a pericardium to extend the posterior leaflet. So that I've been a part of. So it seems
Just a question on that patients. Were they congenital patients or rheumatic
these are
patients?
rheumatic. Most of them are rheumatic.
Yeah, the rheumatic is kind of different than
Yeah.
congenital patients. That tissue,
True,
it's
true.
you, sometimes you do it, but you know it is not the same thing as the rheumatic peeling. And congenital patients, on rheumatic patients, you have this kind of cleavage and then
true.
layer, and that's you go. With the degenerated and then dysplastic valves, it is not the same.
It works in patients who have a supramitral ring.
Yeah.
And there the
Yeah,
leaflets.
supramitral ring
you
is
can
something,
peel it off,
you just peel it.
Yeah, and it sometimes it comes on the valve and all that. So once you peel it off, the result is very good.
Okay, thank you. The last one is myself. Right. My topic is the long-term result of bilateral banding versus a primary node procedure. No disclosure. The first successful report of Hypoplast is by Dr. Knowles, as you know. And then I present the paper using RBPA shunt. So usually the node procedures include a classical node and then my modification. So this topic, I tried to compare the usual node, like a node procedure, including classical and the RBPA shunt, versus bilateral banding, so-called like a hybrid. And then the recent development of the rapid two-stage. So the single ventricle reconstruction trials said that the mortality after the classical node and then the sonor modification is not a significant difference. The group of aortic atresia have a much better result by using the RVPA shunt. But the aortic stenosis and hypoplastic variant, and the long-term result is not much difference. Either you use the classical or the RVPA shunt. The first report of the bilateral banding is by the Shea in 1968. He did bilateral banding, but at that time there was no prostaglandin and no stent. So this is like experimental trials that the patient may survive a few days, and then when the duct is closing, the patient died. So the recent report of ductal stenting and the bilateral banding was from the Leeds group and the UK. In 1993, the stenting of the arterial duct combined with banding the pulmonary artery and septectomy or septostomy, the new approach. So they have 4 patients in ductal stenting and bilateral banding at 2 early deaths. The hybrid approach, the concept is a less invasive procedure and avoid open heart surgery in neonatal period, and also they avoid deep hypothalamic circulatory arrest. And however, at the second stage, the arch repair combined with the Gren is comprehensive 2-stage. is a big operation, especially the stent is migrated and the damage to the aorta. So these two very aggressive unit, we're doing a hybrid. One is the nationwide children's in Columbus, Ohio, in the United States. The hybrid approach in the hypoplastic intermediate result after learning curve, but by Dr. Galandovich. They have 40 patients and hybrid, the banding, a ductal stent, atrial septostomy, and comprehensive stage 2, Gren, node, and Gren. The hospital death 1, interstage death 2, but the 10% of the patient develop significant retrograde stenosis into the transverse arch. So they put the shunt from main PA to arch to keep the blood flow to the coronaries. The overall survivors was 82.5%. So this is the retrograde aortic arch. They put shunt from PA to innominate. And the other paper from Centuries, the hybrid versus Norwood. The Norwood survival was 81, and the hybrid survival was 58%. And they said the Norwood have a better result, but it's significantly not different because the number is so small. The recent report of the hybrid is from 2 units. One is from nationwide, one is from Gießen in Germany. They have 64 hypoplastic nationwide. Children's mortality at the early stage before 2010 was 19%, and then after down to 4%. And then the Gießen's result is 182 hypoplast, and then the mortality of the comprehensive staged procedure was 7.4%, and interstage mortality 14.2%, and 10-year survival is 78%. So these two groups have a completely different. To me, that the nationwide group, now they changed the protocol of comprehensive stage 2 protocol before 2010 and after 2010. Because they have lots of complications after the hybrid. Here, for example, the pulmonary artery thrombosis after the comprehensive stage 2, and probably because of the pulmonary vascular resistance in the right and the left lung is different. So very easy to thrombose, especially to the left side. So after the comprehensive stage 2, they do angiography, and then sometimes they put a stent to the left PA to keep open the left PA. So and also the preoperatively, they recommended to do a comprehensive stage 2 around 3 months, but in the recent protocol they changed at the age of 5 months and not less than 3 months, and no emergent comprehensive stage 2 procedures, and also the If the PA is small, they prefer to put a shunt to increase the size of PA. And also the compression angiogram to evaluate after the Glenn and to check the branch PA flow. The post-operative early extubation, the post-operative anticoagulation, very aggressive anticoagulation, and then before discharge, they do consider additional pulmonary artery imaging because they have a lot of complications of PA thrombosis. That's why the result is improved. But then the Gießen group is completely different. They didn't change the policies and the protocol. The Schlantz and the cardiologist, the very aggressive cardiologist, and a very good fan of the soccer, crazy soccer man. The 15-year single-center experience with the Gießen hybrid approach to the HLHS and the variant, they have an excellent result. The protocol is the same from the beginning. So this is the data, the 182 patients and the hybrid stage 1 and 126. And then the comprehensive stage 2 and the Fontan. But to me, only 62 patients reached to the Fontan. That's only half. 26 are waiting and 4 are waiting. Lots of patients moved to a transplant. So if you carefully check their result, the 62 patients at the Fontan, and then the 30 patients are waiting, so at the maximum of 92. And out of 126 is maximum survival rate is 73%. And then they have a 2 late deaths and 2 late transplant. So the 4 patients after the Fontan died. So to me, that means the long-term survival or the transplant-free survivors is only 63%. So it's not that the very bad result, but it's not completely much not much better than the Norwood procedures. So the STS database on total 1,700 patients. In North America, they prefer the Norwood, and 87%, and Norwood, and then the hybrid is much less, and then mortality is Norwood is 15.7%. The hybrid is almost 30%. And then in Japan, Dr. Mitani in Mie University, he published a paper, the continuous infusion of prostaglandin E1 to keep the duct open instead of duct stenting, and they do a comprehensive stage 2. But using this technique, the new options appeared. The rapid stage bilateral banding, and not to wait 3 months or 5 months. So this is the data from I think from Shizuoka Children's. Is a routine and a rapid stage bilateral banding before stage 1. So 2 to 4 weeks after the band, they do the Norwood. The difference is the shunt type and the bilateral band group have much more classical Norwood, and the primary Norwood they prefer to use in RVPA. But the quite significant difference is the post-operative cost and a much better urine output in bilateral banding and rapid 2-stage group, and the lactate is much less in the rapid 2-stage. And the mechanical ventilation duration is much shorter in bilateral banding. And the other strategy is the rapid two-stage, only the high-risk patient. This is a patient from the UK, St. Thomas guys, and they use this strategy to a high-risk patient. The mortality is quite high, but these are only the high-risk patient. This is the high-risk one, non-banding, and then the banding and the rapid two-stage. Sorry. This is our result of all the hypoplastic patients in this stage 1 survivor. And after the RBP shunt is 92%, and the overall survival in the 8 years is 75%. If we only analyze the normal risk patient, and excluding the premature low body weight, and then severe tricuspid regurgitation, and then genetic abnormalities, the stage 1 survival is 95, and then 8-year survival is 87%. So we changed our policy of doing the first stage 1. We now changed the bilateral banding and the rapid two-stage to a high-risk patient. If the patient is the body weight is like 2 kilos, we do bilateral banding. Wait until the body weight increases to 2.5, so that no risk factors. Severe tricuspid regurgitation, we do annuloplasty, and then the weight, the bilateral banding, the weight. If the intact anterior septum restrictive ASD, we do catheter-based ASD creation, or surgical creation ASD, and the bilateral banding and the weight. So that when we do a Norwood, then the patient have no intact atrial septum, no restrictive ASD. So the 28 patient we did bilateral banding, but the 8 days, the half of them a true intact atrial septum. We did operating within 1 hour after birth. These are the very bad candidate, and also the severe tricuspid regurgitation. It's very difficult to control tricuspid regurgitation. So, but the good candidate is like a premature or the body weight is small, or the shock patient. These survived, and then the 15 patient had a node, and the 4, and mostly because of the infections, and we waited for 2 or 3 months, and then we did. These are our early experience. We did no and Glen at the same time, but the result was no good. So the recently we have more rapid two-stage, and one is because of the fetal echo, the many of the high risk patient are referred to us. So we have this one. We prefer to do rapid two-stage. This is the Japanese database of the long-term result of bilateral banding versus primary node procedure. This is the whole country's result. This 304 and hypoplast. The unit, many of the units are doing only 1 or 2 cases a year. The only few centers are doing like 5 or 10, but it's the mostly very few cases. But these are all included. So the primary node and bilateral banding, the patient with like a low body weight, less than 2 kilos, almost all patients had the bilateral banding, and the primary node is 0. So in Japan, even the unit or surgeon prefer to do primary node. If the child have a very high risk, they prefer to do bilateral banding. And then the less than 2.5 is mostly majority bilateral banding. Some of the patients have had primary node. The same with tricuspid regurgitation, more moderate. Many units prefer to do bilateral banding. And then also the ascending aorta is very much hypoplastic, and many units prefer to do a banding. This is the total result of the 334 patients, the bilateral banding and rapid 2-stage and a node, the primary node. So just simply see this graph. The primary node group looks much better than the bilateral banding in the rapid 2-stage. But on the other hand, the high volume, not high volume, but it's the 5 to 10 cases a year on these units prefer to do a primary node in the usual patient, except exclude the high risk. The very low volume centers prefer to do rapid 2-stage, so that the experience is different. I don't think the banding is a much worse result. If the more experienced unit to do bilateral banding in 2-stage, probably the result is very much similar to primary node result. Oh, that's the same one. So now the node procedure is commonly used compared to the hybrid as a first-stage palliation for hypoplastic in North America. And the rapid 2-stage node procedure is recommended to especially the high-risk patient with hypoplast, or the unit where the case volume is very small. Thank you very much for your attention.
Dr. Sano,
Yes.
what is the protocol for PDA with the rapid 2-stage when you do the bilateral banding?
I think the
patients on PGE?
As most of the units are using a PG1, not stent. Well, mostly like 1 to 3 weeks. So they keep the patient in the hospital. If something like the unplanned thing happens because of the infection, something more abnormal or necrotized endocarditis, and they need to wait more, some of the patients, the cardiacs put a stent, but the majority controlled by PG1. In Japan, we have an IV, not only IV PG1, but also the oral prostaglandin, which is much less side effect. And sometimes you can control the patient at home. But unfortunately, not in the United States. It's not allowed. Japanese drug not allowed. Prostaglandin only IV, not oral. The oral PG1 is developed in Japan. The American fast. In the medicine too.
That was a very nice presentation. I have a small problem understanding the concept of the bilateral bands and the PDA stenting. Initially, when they started this procedure, they were limiting it to very high-risk patients who were not good candidates for a Norwood stage 1. But as the technology has progressed, now they have started, particularly 1 or 2 centers, that is their preferred strategy of initial palliation. And that would also be for not only for high risk but for good risk patients. So are we not comparing apples to oranges? Because these two patients, the patients who have a good anatomy and who are not high risk would have had a good outcome with the Norwood itself. So why push them for a hybrid strategy and complicate things further?
And I think the unit is much less experienced. If you do rapid 2-stage, you can do a Norwood operation and after the neonatal period.
But why do that? So
because the neonatal the result is no good. So they prefer to do, but the experienced unit or the unit where there are lots of like a neonatal operation, they don't worry about.
Yeah.
That's only the like a mental problem.
Yeah, because if you do the Norwood, the results are probably actually even better than the this BA band, because when you go to the next stage and they're taking out the stent and bands and all, they will produce the lot of stenosis of the pulmonary arteries. You pull out the band, you can damage the heart or something. So at the second stage, it becomes very difficult with that. So for low risk patients, I still believe that Norwood is the gold standard. So the papers which say that the bilateral PA banding has good results as compared to Norwood or as comparable results, I think it's a skewed distribution. It's not fair and accurate scientific information.
And I think the Shizuoka Children's they published a paper. I think the result is probably almost same, but the post-operative course is more stable.
Yeah, that's.
Yeah, and also if you do rapid 2-stage in 1 or 2 weeks after the band, you don't need to repair the pulmonary arteries.
Yeah.
And also because of the no stent, the Norwood procedure is much easier to do it.
Yeah,
if you do the stent, it's more difficult. And wait more, 1 or 2 months, you need to repair the pulmonary artery, which is more complicated.
But then you have to keep the patient in hospital for 2-3 weeks, and he may get the infection from the hospital. Get infection when he was not infected initially. So he may get infection from the surroundings.
I think the Japan, because of the hospital fee is covered by the government insurance, the family do not want to be back.
Yeah, but in the United States,
United States different.
So they'll spend, I think, more than $100,000 if they stay in the hospital for 2 weeks. The other thing is like they will catch infection. Now in Japan, I was interested. What you said was the oral prostaglandin. So are the patients sent home on the oral prostaglandins or they stay in the hospital?
I think some of the unit, if the family is live very close, some of the patient back home, but mostly they keep the patient in the hospital, which is much safer.
Okay, like in the countries like India, like if you keep the patient in the hospital, with every passing hours, there's an increasing risk of getting an infection.
Yeah.
If you do a straightforward switch, he does not get extubated in 2 days, you're sure that he's going to start growing bacteria or something in his endotracheal tube, and that will worsen the outcome. So I don't think this strategy is going to work in those countries where you have hospital-acquired infections. And you have to be very clean and free of infection.
Yeah, that's different. Yeah.
Small information. In Japan, there are so many institutes. So many institutes had one consultant surgeon. So if the consultant surgeon have a responsibility to all 365 days. However, together with bandings, young persons can do. So that's very easy to use this bilateral banding procedure in Japan.
Yeah. The question? Yeah.
Thank you for your presentation, Dr. Sano. I would like to ask about if the patient have a restrictive atrial septum, would you like to do atrial septectomy when you do the bilateral PA banding, or do you want to use the stent in the ASD? Thank you.
No, I think not many experience of a true intact atrial septum, but it's a true intact ventricular septum. The atrial septum was very thick and very difficult to do a balloon dilate. So on all the patients, we did like open chest, just after the birth, transfer the patient to the OR, change the OR, straight for the open chest, and then through the echo guidance, the puncture from the right atrial appendage, and then they do like the balloon dilate, and then next day, quite often next day they do like a stent. Yeah. If we cannot do it, then put on bypass.
Most of the time it's not needed.
Yeah. Yes.
Some kind of slit to go across the septum.
Yeah. If you experience it, you puncture through place.
Yeah, and then it can be dilated, and then you put the stent across.
Yeah. It's possible. Yes. Yeah. Initially, we did like soon after the puncture, the saturation go up below 50 or 60, 70, and we're very happy. Next day, down again. So
How do you know that you've gone across the septum? Use a PE or something? How do you know that you've gone across the septum?
From the echo, just intraoperative, not T, intraoperative echo. From here. So the cardiologist scrub and then stand in as like assistant position. They do like an echo and I do puncture.
Actually, if you're saying it's in the open sternum, then you could do an epicardial echo also. The surgeon could do an epicardial echo.
Yeah.
That will give you better than a transthoracic.
Yeah.
The epicardial echo will be more accurate.
Yeah.
And easy for surgeons to do because they can get a better visualization of the septum.
Okay, thank you very much for very active discussions. We close this session. Please come the second afternoon symposium with the 30 minutes. I think it's 3:30. The second 3:30. Yeah.
Small break.